Bom dia a todos. Hoje temos a honra de receber o professor Muthu, dando sequência à nossa série de webinars, Cirurgia Ambulatorial, um conceito centrado no cuidado multidisciplinar com foco no paciente. É uma constituição do trabalho da Sociedade Brasileira de Cirurgia Ambulatorial, a SOBRACAM, que busca fomentar o debate transdisciplinar que permeia a estratégia de cirurgia ambulatorial em nosso país. Nosso intuito é apresentar diversas formas e panoramas de experts que praticam a cirurgia ambulatorial em seus mais diversos aspectos em todas as partes do mundo. O professor Muthu, ele é chefe do Centro de Pesquisa de Cáries na Primeira Infância do Departamento de Odontopediatria da Faculdade de Odontologia do Instituto de Educação Superior de Sri Ramachandra, em Chennai, na Índia. Foi o quarto odontopediatra indiano a obter seu doutorado e é membro do Royal College of Physicians and Surgery em Glasgow, na Escócia. Sua formação inclui especialização na Universidade de Washington, em Seattle, nos Estados Unidos. Publicou mais de 70 artigos em periódicos indexados, incluindo 10 artigos de revisão sistemática, sendo 4 deles pela Cochrane. É autor do livro-texto de referência em odontopediatria, utilizado pelas universidades indianas, e recebeu diversas bolsas de pesquisas, inclusive do Wellcome Trust, no Reino Unido. Ele é integrante do comitê de membros do IAPD, é secretário-geral da Sociedade Indiana de Traumatologia Dentária, secretário adjunto da Sociedade Indiana de Odontopediatria e Odontologia Preventiva. O mais importante para a gente, ele tem vasta experiência com tratamento ambulatorial de pacientes pediátricos sob anestesia geral e hoje vai compartilhar conosco essa experiência. So, Professor Muthu, I was just introducing you to our audience. I wish to tell you that I'm personally very glad to have you with us today. So on behalf of SOBRACAM, I would like to thank you very much for your participation. Please, the word is yours.
Great.
Thank you. Thank you very much, Dr. Valkyra Mora and the Brazilian Society of Ambulatory Surgery. I consider this as a privilege to address this wonderful set of people. So the title for the presentation is Pedodontics under General Anesthesia, Indications, Results and Safety Issues. And so I currently the head of Center for Institute Caries Research in Sri Ramchandra University. This is this city is in Chennai. This is the southern part of India. These are the major metropolitan cities in India, and I belong to this place down south of India, that's called Chennai. And this is one of the 4 major metropolitan cities. I come from this place. So going to the presentation. So this is going to be the outline for my presentation. I have a brief introduction, and then we will look at indications for general anesthesia, and we look at the results, some of the pre and post treatment pictures of children treated under general anesthesia, then briefly about the safety issues, and we will conclude. So that's the brief outline of today's presentation. And to start with the introduction, if you look at general anesthesia, if we go through the American Academy of Pediatric Dentistry guidelines on behavior guidance, there is something called basic behavior guidance and advanced behavior guidance. The advanced behavior guidance primarily talks about 3 major entities. One is protective stabilization, the second one is sedation, and the third one is general anesthesia. So we are going to talk about the third part of the advanced behavior guidance, and that's going to be the remaining session about. And general anesthesia is very much an integral part of pediatric dentistry. Okay, so There are many aspects, many domains, many various, but general anesthesia is one major segment, an integral part of pediatric dentistry, and it has very clear indications and contraindications. Okay, when to use general anesthesia, when not to use. So we will be looking at the indications today. If you look at the training, as far as in India is concerned, to a large extent, I think Brazil and India have probably a large number of dental schools. So the training in terms of dental schools in India, we have around 308 dental schools. Out of that, 160 or 170 or maybe around 180 dental schools offer advanced training in pediatric dentistry. That is a master's program in pediatric dentistry, and they do train the postgrad students in general anesthesia. It's mandatory, even though not all the schools adhere to that, but majority of the schools have some kind of exposure in master's degree. And in our university, we have a very, very structured program. Every Monday, we do procedures under general anesthesia. And we also send the undergraduate students, those who are studying dentistry, to go as an observers on rotation on every Monday. So even a graduate student gets some exposure. They go to the operating room and stand as an observer there. So it's a pretty kind of reasonably familiar way of functioning. And as far as I'm concerned, I had this training since my master's degree. I did my master's in 97 to 99. So we had a general anesthesia facility inside my department. So we used to do procedures every Monday and Wednesday. These 2 days we do operate children with special healthcare needs or full mouth rehabilitation like that. So that's a pretty, probably more than 2.5 decades of experience in general anesthesia. If you look at the indications for general anesthesia, there are primarily the most common number one indication, if you look at is very young children with multiple dental treatment needs. And the most common reason is early childhood caries. And as pediatric dentists, we all agree with this. And if you look at very young children, what does that very young means? Any child who's less than 3 years, 3.5 years, 2.5 to 3.5 years of age, we categorize these children according to the Wright's classification of child behavior. They lack cooperative ability, right? So it's not that they do not want to cooperate. So they lack the ability to cooperate. So these very young children, when they have multiple dental disease, multiple teeth to be treated, and they do not cooperate on the dental chair because they lack the ability to cooperate. So this is the most common need for general anesthesia in pediatric dentistry. So if you look at it, the second most common need is children with special healthcare needs. Children with mental retardation or cerebral palsy or autism, when they have dental needs to be met. So most often they also lack the ability to cooperate on the dental chair. So we invariably take the children under general anesthesia. So, and the third set of people are extremely fearful and anxious children. Okay, this can be even older age group, even they can be 5 years, 4 years, or even at times 6 or 7 years of age, where they have multiple dental issues. You can as well manage under sedation too. However, if the treatment needs are more, the number of teeth to be treated are more, and invariably we do it under general anesthesia. Okay. And at times where you have children with traumatic injuries, very young children with crown or crown root fractures or complicated crown fractures, where you need to preserve the teeth, but they are too young to sit on the dental chair, and you need a very, very, kind of a pulpectomy and a strip crown pulpectomy and zirconia crown on anterior teeth. The child is 2.5 years with a crown root fractures, can be very classical example for this category. So these are the most common. Mainly the first one is predominantly the very common reason. The second one is maybe the second most common, and other overall, probably I can put in simple words, these are largely the indications for general anesthesia and pediatric dentistry. So if you look at, I'm just going to run through some of the pictures of different age groups of children. So this is a 3.5-year-old child with a full-fledged early childhood caries. You can look at it's extending to the posterior molars as well. And pulp exposure is there. You need to probably do a pulpectomy and a zirconia crown or a strip crown, depending on the need, or anterior stainless steel crown. Of course, we don't use that much now after the advent of zirconia crowns. And this is another 3-year-old child where, because I put this as main need for general anesthesia, because when you want to do a strip crowns on these patients, you have to finish the gingival margin after the procedure, and the child has to be absolutely still to do the procedure safely on them, and at the same time the quality of care, right? So it's very crucial. These are very classical situations of early childhood caries. This is a 3-year-old child. If you look at even the canines, we might think, okay, we might be able to do a class 5 filling on a canine, but again, you have to finish the filling at the gingival margin, and you might have to give multiple local anesthesia. You might want to put a strip crowns, and even the lower incisors are partly involved, and when the posterior teeth as well as involved. So these are all very, very technique sensitive procedures where the children may not sit on the dental chair and cooperate for the entire procedure. Even by chance, if they cooperate for 1 or 2 teeth, as we go along with multiple teeth, and subsequent appointments can become very difficult. This is a 3-year-old child. And this child is a 1 year and 9-month-old child. You look at the extent of damage, it's very, very difficult scenario. Most the maxillary central and lateral incisors are completely broken down, and you have lesions on almost all the teeth. Okay, very active carious lesions. And this is one of the very young children. This is an 18-month-old child. I'm going to show you the pre-post treatment and follow up this child's pictures in the subsequent slides. This child, we did this procedure in 40 minutes. We put four strip crowns under general anesthesia. The mother is a gastroenterologist and the father is a orthopedic surgeon. Okay, these are very classical scenarios. This is a child, 16-month-old. We brought this teeth back with the zirconia crowns. These are all very, very typical examples where if you want to preserve the teeth, we can attempt only on general anesthesia. Of course, removal of these teeth can be done under protective stabilization. But if you want to do pulpectomy and put a zirconia crown on that, you might need general anesthesia because they are very, very technique sensitive procedures. And this is one of the youngest child I have treated in the last 20-25 years. There's a 14-month-old child that incisors have barely erupted and almost already broken down. This is a very short procedure. We did it for around 30-35 minutes is the entire procedure, including intubation, extubation. We put 4 strip crowns on this patient. Again, the parents are doctors. The father was an ophthalmologist and mother was a nephrologist in this child. So some of the pictures, I'm going to show you the pre and post treatment pictures subsequently in this presentation. If you look at the basic information, about general anesthesia, we call this as a daycare procedure. I heard from the doctor yesterday that it's called ambulatory surgery there. And in India, we call it as a daycare surgery or a daycare procedure. And that means you come to the hospital in the morning, you get the procedure done in a few hours, and the same day you go out of the hospital. And it's a very routinely we are doing since last 2 decades, probably 99 onwards. We are operating in a private setup where I have my practice. And it's a very, very common day-to-day affair in Chennai. And the total hospitalization, I'm going to show you the pictures of the operating room where I operate. And it's a very simple scenario here. The patient comes early morning at 4:30 a.m. or 5 o'clock, and half an hour, 30 minutes from the time of their admission, we start the procedure. So we operate at 5:30 a.m. or 5 o'clock in the morning. And typically the procedure lasts for 1.5 to 2 hours. That's the most common duration a pediatric dentist operate in the setup here. There are times we do 1 hour procedure or 45 minutes procedure. There are times we do 2 to 3 hour procedure. But irrespective of that, entire hospitalization will be 6 hours for the child. They come in the morning, half an hour before the procedure, 30 minutes before the procedure. We do the procedure for 2 hours and keep them under observation for another 60 to 90 minutes, and they go home. And the child goes to school next day morning, okay? And it's a very, very superb way of rehabilitating these children effortlessly, and the quality of care can be great. So we have a setup in a dedicated dental surgery center. They don't do medical surgery there. In fact, a team of pediatric dentists came together and we created that facility almost 20 years back. And at that point of time, we used to operate, personally from my side, from my practice, we used to operate 4 to 6 procedures in a year. I'm talking about early 2001, 2002, at that point of time. Those years, we used to operate only a handful of procedures per year. But now we do around 8 to 12 procedures in a month. Before the COVID pandemic, now we have kind of slowed down because of the pandemic, but still we operate. We do a COVID test for the child, and we operate. If the child is negative, we go ahead and do the procedure. We resumed functioning 3-4 months back. So we have a dedicated dental surgery center. There is no medical surgery happening here. The entire hospitalization is only for 4 to 6 hours. And in a year, currently they operate around 600 to 800 children in the center. Okay, technically that makes it almost 2 child per day, every day almost at an average. Sometimes they do 3 or 4, but some days there are no procedures. But the average number is around 600 to 800 children. In Chennai city, there are around 150 to 200 pediatric dentists are there. Almost 95% of them operate in the same place. So the patients can be from different place, but they all come to the same center for general anesthesia procedure. So that's why it's one of the best system to get in one city, one major city. You can have one dedicated dental surgery center. You can rehabilitate hundreds and thousands of children. And in India, in the entire country, our center is the largest center for dental rehabilitation. We do the maximum number of pediatric dental rehabilitation in the center. So it's a fantastic, simple facility. And the approximate cost of the procedure ranges from around 800 to $2,000. That's the entire cost of the procedure, including the dental procedure, the anesthetist cost, hospital cost, dental treatment, dental materials, everything including. So the whole thing, there are patients who come from other cities. They come in the previous night. Next day morning, we operate, and following day they leave. So technically, it's a very, very efficient facility. And one of the pillar behind this is my anesthesiologist, the pediatric anesthesiologist. Because of him, we operate. The pediatric dentist might be different, but the anesthesiologist for all of us is the same. So it's a pretty well organized facility. And in the clinic, in my private practice, we do something called ECC consultation. There is a general consultation for children, and there is a ECC consultation. So in the ECC consultation, we talk about the need for general anesthesia and the quality of care, what they will get when we do that. And if we do the procedure on the dental chair, what are the risks of injury to the child? And of course, the sensitivity of dental materials to moisture and accidental injuries or aspiration, all these things are explained to them, why we cannot treat this child on the dental chair and why we need general anesthesia. So we have this called ECC consultation as a separate entity. We spend around 15-20 minutes to explain them, and we have pre and post treatment pictures of the children before treatment and after treatment and things like that, so that they can understand what is a strip crown, what is a zirconia crown, what is a stainless steel crown look like. So all these things we show them in the clinic during our consultation. Okay, so it's a pretty very efficient consultations we do. We also teach in my department this as a separate session. You know, what is an ECC consultation? How do you explain the need for general anesthesia to the parent? Okay, so it's a very systematic way of doing things. And if you look at the medical steps, what we do is we ask the patient after they consult the pediatric dentist, they meet the anesthesiologist prior to the procedure. So the child goes with the parent and they go and meet the anesthesiologist in the same setup where he operates. So they know where the center is and the anesthetist explains the risk. Sorry for the typo there. He explains the risk, and he says the pre-anesthetic instructions and all those instructions mainly about nil by mouth, because 6 hours prior to the procedure, the child should not have eaten or drank anything, not even water, preferably. So these instructions are given. The anesthetist also evaluates the child's throat and whether the child needs any investigations. So those things, decisions are taken during this consultation, and the parents are advised accordingly. And the anesthesia is induced by thiopental sodium. That's an ultra short acting barbiturate. And when we use a gas induction, we use a sevoflurane gas, and the anesthesia is maintained with nitrous oxide oxygen and isoflurane, and sometimes sevoflurane. So this is the most common gases which are used to maintain the anesthesia. And if during the procedure, if there is any analgesia needed, we add fentanyl. If the local anesthesia what we give is not sufficient, and if the child has some attempts during the procedure, we add fentanyl for more pain control. And the anesthesiologist intubate the child using nasal intubation. That's the key. That's the bottom line. That's the game changer. So you need an anesthesiologist who can intubate a child through the nose. So you have to, most of the anesthesiologists are familiar with intubating through the oral cavity, but you need a very, very skilled pediatric anesthesiologist who can do this effortlessly, okay? So the other medicines which are used are muscle relaxants, the tracurium and vecuronium, and these are used for muscle relaxants. And once the anesthesiologist makes the child sleep, he also puts the throat pack with a gauze roll, and he hands over the patient to the pediatric dentist. Okay, so during the dental procedure, what first thing we put mouth prop. We put the mole's mouth prop on one side, and we operate on the other side. Okay, and how do we do that? First, we do a oral prophylaxis on the side which we are working. Then after the oral prophylaxis is done, we do restorations and sealants, because we don't want bleeding to come and contaminate the teeth surfaces. You can also do it under rubber dam, and which can take care of that. So we usually do the posterior teeth first, and we do the pulp therapy and stainless steel or zirconia crowns after the restorations, because the preparation of the zirconia crown or stainless steel crown can lead to bleeding. So then we put the mouth prop on the other side. So we go from right to left side, we work on the left side. And then now once it's done, same steps we followed: oral prophylaxis, restorations and sealants, pulp therapy, stainless steel crown or zirconia crowns. And then we do the extraction. Then we come to the anterior teeth. Okay, if there is any extractions on the posterior teeth. Then we put the cheek retractor, you do the anterior teeth, we do strip crowns, restorations and zirconia crowns, and we do the extractions in the anterior region at the end. And at times we put a suturing, or we also use gel foam to control the bleeding. So some of the clinical tips during the procedure is, when we take a burr, say for example, a round burr, whatever we have to do with the round burr, we will do at one go in that side, whatever teeth to be done. So then the time needed to change the burr to another burr is minimized. We don't do, whatever, I hope I'm making this point clear. You take a burr in the entire right side, whatever to be done with that burr, we will do it. And then we go to the next burr, and like that we try to save some time. And also mole's mouth prop is better than the Meckerson bite blocks. So the mouth props are pretty good because it gives you more space to work with your hand pieces. Bite blocks tend to kind of slightly restrict the space available. And we also put sutures. Sometimes you put gel foam in the extraction socket so that it can control the bleeding. And while doing zirconia crowns to control bleeding, we apply pressure. We don't use a hemostat. This is a technique which we use. Primarily I and my team use this method. So we hold it with a gauze to control the bleeding. And the cement is mixed and loaded on the crown, and it's given to you. And just before inserting the crown, you take the pressure off, and that will have very effective bleeding control. And if you're using anterior stainless steel crown, those who are not familiar with zirconia crown and they are still with anterior stainless steel crown, we cut the, this I'm telling, we don't use anterior stainless steel crown nowadays. Almost 5 years back, since once the zirconia crown came in, we almost stopped using anti-stainless steel crown. But when we used to use anti-stainless steel crown before, we used to cut the window in the clinic only. So inside the operating room, you can save time. Okay. And we generally have two dental assistants. And when we have strip crowns on the anterior teeth, in the beginning of the procedure, we take choose the appropriate size strip crown and give it to the other assistant. So that assistant will cut the strip crown and keep it ready as we are doing some other procedures. So technically, these are all some time-saving strategies. Some pictures of the operating room. Okay, so this is a picture which was taken 3 days back. No, not even 3 days. Yesterday morning, I had a procedure, so I specifically took. This is my anesthesiologist, and right now we have a little more steps to take care in the operating room. And this is after the intubation. We do a nasal intubation. You can see the tube placed. That's the assistant for my anesthesiologist. We had a full mouth rehab, and then we stabilized the tube. If you closely observe, the tubes are stabilized, and we put a small tape on the eye so that water or nothing falls on the eye. And it's a micropore tape basically. And once now the tube is stabilized in the nose, so that even while you're operating, it doesn't get dislodged, and it's being monitored by the anesthesiologist. And this is me, and you can look at, there is a table on the right side. We have this full PPE now with the shield and a lot of other stuff. Before that, we just used to work with a mask and goggles, of course, with the operating room suits and other things. But we have a little more additional protection now. And so that's the back view. So this is the dental unit. If you closely observe, you can see the scaler, 3-way syringe, and the arrow to drill. So you have to create, this is what I meant by a dental surgery center. Okay, it's very important you create a dental surgery center so that you get a compressed air inside the operating room. And we also have a digital X-ray machine. So this is when they're extubating, because that's the time the child coughs. We use disposable, these tapes. This is all my anesthesiologist's method, so that there is no, even though child is tested for COVID and the reports are negative, and we try to take as much precautions as possible. These are X-rays. We have a digital X-ray inside the operating room. So whatever X-rays we want, we can take it, and it's ready for viewing immediately. This is the X-rays which we taken yesterday. So if you look at the results, what kind of rehabilitation we do. I would like to see these procedures. Some of them, I've kept 2 or 3 cases of strip crowns and 1 or 2 cases of zirconia crowns, so that what kind of results you can get. I try to keep a little bit of a variety there, and so that you can understand. This is a child treated a long time back. So this is a classical early childhood caries with all the incisors involved. This is the strip crowns. I'll show you the sequence of pictures with the time frame. This is the immediate post-op. This is November 2013. The pre-op post-op procedures pictures. This is in January 2015. Okay, that's almost 12 to 15 months post-procedure. Okay, and I have some more follow-ups of this. So this is January 2015. And this is little more September 2015. Okay, you can see the lower incisor has exfoliated, and some more. The upper incisor, upper strip crown, one of the strip crown is exfoliated. This is February 2016. Lower permanent incisors are erected, and upper permanent incisor is erected September 2016. And I have another one that is March 2018. Okay, I'll just quickly show this picture in a sequence. Okay, so this is Feb 16 we start, and September 16 and March 2018. So if you look at the overall picture, okay, this is where we started, that is November 2013, and this is the immediate post-op, and this is almost 5 years down the line, 53 months, close to 5 years. Okay, so these rehabilitations are very, very, very common. We are doing for years together now. We train all our postgraduate students in this. By the time they finish the course, they have done numerous procedures full mouth rehabilitation during their master's degree. So we are training the students for last 20 years. So every postgraduate student who have stemmed out of my department have been trained in this procedure. And as I told earlier, the probably 100, 150 postgraduates in my city, pediatric dentists in my city, almost many of them, at least probably 30 or 40 of them are my own students. So all of them are well versed. We operate in the same operating room with the same anesthesiologist for years, and we have a fantastic setup. And this is another child. This is one of the pictures which I showed in the beginning of this presentation. I told you the gastroenterologist and the orthopedic surgeon. This is a 16, 18-month-old child with a very early breakdown. We were not using SDF and all those kind of things at that point of time. This is September 16. We took her for a short GA because as far as my understanding goes in early childhood caries, if the child takes, prolongs their nighttime feeding, sleep time feeding, the teeth breaks down very fast. Okay, so it's very, very critical that immediately this process should be arrested. So we did a very short general anesthesia. This is the immediate post-op strip crowns. Okay, that is September 2016. Okay, this was an entire procedure was 40 minutes, 10 minutes to intubate, 10 minutes to extubate, 20, 25 minutes we do the procedure. Okay, because it's only a strip crown, there is no pulp therapy involved in this. And I'll show you the follow-up of this picture, this child. Okay, this is September 16. This is immediate post-op, and this is taken this year. This is January. I have a sequence. I can show you hundreds of pictures or cases pre and post procedure at various levels. And this is one of the youngest child we've treated. You look at January 2020. If you closely look at the right maxillary right central incisor, the tooth is not completely erupted when we place the strip crown. So you can see that there is a slight margin and with the intact tooth structure there, right? So pretty intact, and of course there is slight amount of discoloration which happens with strip crowns. But you do a zirconia crown, you don't have this problem of discoloration. Now we use a lot of zirconia crowns. We use new smile crowns predominantly. Okay, this is after 41 months of the treatment. Okay, I have because we have 35 minutes. I try to keep a variety of procedures to show you the results what we get. And this is a couple of examples of severely broken down teeth. We rehabilitate with zirconia crowns with a slightly different technique. Okay, we call this a bite raising technique. Soon you will see a published paper on this. Okay, so this was a child. The patient moved to the US after the procedure. So I have a couple of months follow up, I think. This is how the teeth was. So in the earlier days, we used to do anterior stainless steel crowns on these teeth. We used to rehabilitate these as well. So now we do the zirconia crowns. This is the immediate post-op. This was in June 2018. This procedure was done. We've been using zirconia crown since 2013 or 14, soon after its launch in IPD. So this is June and this is July. Okay, so this is a month later. So if you look at, there is actually technique wise, yes, there are, the gingiva should not be lacerated like that. That's, there was accidentally the bird slipped on the gums. So that's the tear. But if you look at, this is the beauty of zirconia, where it doesn't allow any plaque formation or biofilm formation. The gingiva adapts to the zirconia crown like how it adapts to a natural tooth. So the follow-ups and the post-operative results are unimaginably stunning with the zirconia crowns. Okay, so this is July 18. So this is where we started. Okay, and this is after a month. Okay, and I'll show you the other patient, which is of a longer follow-up. I have probably different series because I primarily put this because patient travel from outside the country, come here and rehabilitate because it's a one-day job. They come, they stay for a day or two, and you can get it done because the entire procedure is done in 5 to 6 hours. The maximum is 6 hours. So including the procedure, including the hospital admission and discharge and everything. So if you look at I have kept one more patient. This is again a severely broken down incisor because what we do is, why I've kept this is, this traditional early childhood caries, we do good amount of zirconia crowns, but these are challenging circumstances where we raise the bite by placing a stainless steel crown on the back teeth. On the first primary molar, we put a stainless steel crown, and the bite is slightly opened. Okay, so now this is the crowns. Okay, this is the immediate post-op. This is again July 2018. Okay, so this is where we started. Okay, this is July 2018, and this is Feb 2019, say probably around 8 months post procedure. Look at the results. You know, I don't think anybody can tell that this child has an artificial set of teeth, except the parents or the relatives who know the child, that the child had a dental problem. This is, as far as a pediatric dentist, I consider this is one of the biggest changes ever happened in pediatric dentistry, in terms of restorative dentistry or rehabilitation of children. You know, the zirconia crowns have changed the name of the game. Okay, so this is Feb 2019. You look at the couple of, I think I have a good follow-up of this. I have series of cases for years of follow-up on various kinds of damage. And this is in Feb 2020. Okay, just before the pandemic. You know, we went in for a lockdown in the month of March last week, and this is just before that. Okay, pretty going strong, and if you do the things right, you will never have failures with zirconia crowns. You know, it's very, very rare to see, or you know, that the zirconia crown fails, because you know, unless there is an injury or a major impact, or if the technique is bad. You know, otherwise technically you don't have much of failures with zirconia crowns. So these are the results. Okay, to give you a sample of the results, the benefits of GA, the benefits of general anesthesia, the overall the results can be extremely gratifying. You know, the rehabilitation can be amazing. The child goes through a big transformation in terms of quality of life, in terms of psychology, and the quality of care is stunning because you rehabilitate fully. You're not left anything. Every tooth is treated, you know, in an hour and a half or 2 hours of time. Okay, and the moment early child is treated fully, then the prevention is sustainable. The prevention, we have very different protocols in Center for Early Childhood Caries and Pedoplanet and Pediatric Dental Center in my practice. So we have protocols for early interventions for early childhood caries. We have protocols for preventing early childhood caries after rehabilitation. You know, the two major game changers in terms of recurrence of caries after rehabilitation is the brushing in the night. The child should go to sleep with a clean mouth. The second thing is the follow-up, the need for follow-up, very close follow-up in the first 2 years, mainly to reassure and monitor the night brushing habits, good eating and oral hygiene practices. So it's very much sustainable the moment you rehabilitate the child fully. And the tremendous change in quality of life, the child's eating improves, the psychology improves, ability to brush, cooperation for brushing improves because none of the teeth is sensitive anymore. All the exposed dentine is covered with crowns, and you see a sea of change in terms of eating and cooperation for brushing and good general health because the child starts eating everything well, and less episodes of visits to the pediatrician, less episodes of frequent sickness or cough and cold, better eating. Because of better eating, better general health, you can see this, you can enjoy this benefit of rehabilitating. But unless we rehabilitate this fully, this disease is not containable at all. You keep on, they come back again and again after failed restorations or recurrent caries. You know, it's very important to treat early childhood caries completely. And if you look at the safety issues, that's the last part of the presentation. The bottom line is you need a pediatric anesthesiologist. He or she is the game changer. You find one pediatric anesthesiologist who can give anesthesia to very young children. Why I say pediatric anesthesiologist is, I'll tell you where you can find them. And these are the other things you might need in the setup. You need all the emergency drugs. Obviously, an operating room has everything, have defibrillators, everything, and preferably a nearby hospital in case if you have to shift anybody. In the last 20 years, we never, ever shifted a child to a hospital. Okay? This is one of the biggest success stories in this country in terms of rehabilitating children on general anesthesia. And it's good to have a very good pre-anesthetic assessment and medical history. So, and also consent for the procedure. Okay. So some suggestions how, as I heard from the doctor yesterday, it's not happening in Brazil. Some suggestions for the pediatric dentist there. The best thing is to, if you're in a major city, definitely I'm sure you have 100, 150 pediatric dentists, okay? With 300 plus dental schools in Brazil, obviously you will have more pediatric dentists as well. So a team of pediatric dentists come together, okay, decide that we'll operate in one same place. Okay, convince a hospital to allow them to operate regularly if you don't have a dental surgery center, or if somebody has set up or space, you can set up an operating room, or you find a hospital, ask them to give you a day, either a Monday or a Wednesday or a weekend, you know, whatever you prefer. So that day is assigned for dental procedures. So all the pediatric dentists put together, if you operate 1 or 2 procedures in a week overall, then the hospital will see that, okay, this is happening regularly. So now more and more people will start utilizing this facility. So that's what we did. We set up a facility, common facility. We threw it open for all pediatric dentists. So they pay a fee for using the theater, and all the expenses are covered. Anesthesiologists paid separately for the procedure. So it's functioning now. Where we used to operate 10 to 20 procedures in a year. All the pediatric dentists put together. At that time, there were very less number of pediatric dentists. Now we do around 600 to 800 procedures in a year. That's a pretty steep hike in the number, right? And still thousands of children in Chennai alone goes untreated, because this itself becomes a little unaffordable, and there are numerous children are treated in the dental university. In the university setup, the cost is less. So hundreds of children are treated in 3 or 4 major dental departments, including mine. And training is needed. You can consider, I just put this here as a part of I'm part of this team. There is a training called MRP Hospital Dentistry. They have a lot of program runs on in the name M Square RP. It's called Meaningful and Measurable Research Progress. They have a program. I'll show you the flyer in the couple of slides. And the key, the bottom line, the one take-home message is find a pediatric anesthesiologist who can intubate a child through the nose. Okay, the key player, he's the main person, the man or the woman who's a pediatric anesthesiologist. Find somebody who's operating with cleft lip and palate children. So the cleft lip surgery to be done at the 3 months, 3-month baby, they operate for the cleft lip, and around 9 months, they operate for the palate. So you need an extremely skilled anesthesiologist to be a part of this team. So ask the anesthesiologist whether he can give anesthesia for a dental procedure. And invariably, you'll find one of them and partner with them. All the pediatric dentists use his services. And the moment you can intubate through the nose, the mouth is free. Okay, so then you can do a fantastic dental rehabilitation. So these are the suggestions for the team who's listening. So this is what I said as an MRP program. Basically, they do a lot of different kind of programs in a startup. It's through a startup, and I'm part of the startup. This is mainly for research training. So they train a dental school or a medical school. You know, they pick up 10 to 15 researchers, and it's a 6 to 9 month program. They mentor them and train them to develop protocols and submit for funding. So in the same way, okay, this is the steps involved in it. Okay, I don't want to go too much into this. I think we are almost coming to the end of my time. So this is one of the project they do. They also have a MRP team where they mentor dental PhD scholars or faculties who are interested in research and developing protocols for funding. This is a 6 months program, and it's for a team of 4 people. They do it online, and I do the dental mentoring, dental team. I handle the dental team. And in the same scheme, this is the schedule of the program. And this is what I was telling. They do a program called, this is predominantly for the international students, a 10-day course on hospital dentistry. And it's called MRP Hospital Dentistry. If you want, I can share this flyer. And it's for a team of 2 people. Okay, if it's we have to look at in a different paper, it's 1 or 2 person, and it's predominantly focused on international students. And a lot of things comes as a part of the thing. They do a series of 10 days, 10 lectures, and 2 to 4 procedures. They allow the foreign national to assist the surgeon in 2 procedures at least, and they also allow you to observe in the university. There's a series of 10 lectures along with the hands-on training on zirconia, and apart from a couple of other sightseeing of the local place, and 1 or 2 persons maximum as a team. And this is the name or the email ID or contact you want to look at. This I just thought because I never knew that there is no facility, or this doesn't happen in Brazil, even though I have some of my friends there, but I didn't know that general anesthesia doesn't happen there. And so this is one thing which you might want to look at it. If somebody's coming to India for a conference, or they can look at it, and that's a very, very efficient program. So to conclude, managing children with early childhood caries is an uphill task. Understanding the disease process is important to provide cure for this completely. Knowledge about the treatment options that last longer. Challenges in providing dental care, chairside or general anesthesia. Availability of the various restorative options like anterior and posterior stainless steel crowns, strip crowns, zirconia crowns, etc. Treatment options that will fail often, and the ability to convey this effectively to parents is important. The ability to decide to treat in the OT or on the dental chair is vital. The changes the treatment can provide to these small children has to be experienced by a clinician. The change in quality of life of these children after the treatment is miraculous. It has to be experienced and cherished. You can experience the sacredness of being a healthcare provider, ability to relieve somebody else's pain, ability to make life comfortable, ability to make the child eat and chew better, ability to make them smile confidently, ability to bring back function, shape, size, color, and many more things for the little ones who never knew what a normal set of teeth was. Once again, we can be proud and privileged to be a pediatric dentist in this lifespan. Thank you very much for your attention, and I'll be happy to answer any questions pertaining to this, or probably even related to pediatric dentistry. Thank you very much.
Thank you. Thank you.
Sharing the screen. Yeah.
Thank you very much.
Thank you very much.
Professor
Thank you.
Muthu.
Yeah. Hope I could give, or kind of give you a broad view of what you wanted. Did I?
Thank you. Brilliant presentation. Very inspiring to listen to you. So I will have some questions to do. And
Okay.
I would like to know a little about the ECC consultation, because you told me that it's another session, but you can talk
Yes.
a little about it?
Yes. Yeah. See, what happens is I've been practicing for last 20 years now, and been treating only children. So it's an exclusive pediatric dental center. In the earlier days, I never used to have this kind of an understanding of the disease. So what I do in the early ECC consultation is we talk about, we explain why this has happened. Because most of these patients have gone to a general dentist, and many times they have told, the pediatricians or general dentists have told, this is milk teeth, it will fall. But in front of their eyes, the teeth have broken down progressively. So when they come back to us, I tell them why this has happened. It's very, very strongly associated with sleep time feeding practices. Invariably, if you ask these 3 questions, whether the child took milk at the beginning of sleep, or in between sleep, or early morning sleep. They take milk at 5 o'clock in the morning, they sleep for a couple of hours. Almost every child at the age group of 2-3 years, they have always it's in a yes, they have this practices, and the teeth comes with enamel defects. So the teeth breaks down, right? The milk accumulates on that. So this part we explain in the consultation why this has happened, because many times parents are not aware that's happening because of one of the main risk factor is sleep time feeding practices. The second thing, they are not aware the child is not able to eat or brush because of the dentine sensitivity. The multiple teeth, the dentine is exposed. So I explained it to them, when so many teeth has dentine exposed, and if you brush, the child will have sensitivity. And also the child tend to keep the food in the mouth for a long time. So this is all happening because the tooth is sensitive. to physical stimulus. So they cannot bite hard substances. So that's why the child takes a long time to eat. So this we explain, okay, why the child is finding it difficult to allow you to brush and why the child is finding it difficult to eat hard substances. So then for the first time they understand this. Oh, so far the child is resisting brushing because the child is having sensitivity, because parents do not know about dentine or, dentinal tubules and odontoblastic, all these things. So we show them these pictures, what I showed you. We have a series of pictures, pre and post treatment. Then I tell them, this is how we bring it back. Your teeth was like this, it can become like this. So they can visually see what changes will happen after the treatment. Then finally, I tell them why we cannot do on the dental chair, because if the child is too young, they might injure themselves because they might suddenly move, and we use very high-speed rotary sharp instruments. And also there is a risk of instruments falling inside the mouth if you do it under restraints, and also the sensitivity of the dental materials to moisture. So you put a filling, saliva comes in contact, the child doesn't cooperate, the filling doesn't stay, because the filling loses its strength immediately, right? So all these things, we explain the need for general anesthesia. When we tell this during the early childhood caries consultation, if in the initial days when we were not doing this, okay, in a sequential way, we consult 10 patients, 1 or 2 patients come back and get the treatment. Now you consult 10 patients, 6 or 7 of them come back and take the treatment under general anesthesia, because they know that this is the only way to provide care. Now we also provide an alternative method like SDF application and all those kind of things, because we offer as a non-invasive method. If somebody is not interested in general anesthesia, the only way to control the disease is the SDF application. So this is what we do, and I teach them. There is a separate session for my postgraduate students, ECC consultation. That's the title. So how do you do this, and what are the consequences of no treatment, and things like that, right?
Perfect. I want to do this class one time.
Yeah, sure, definitely, we will do that. Now we can connect online. It's a pretty now pandemic has forced us to learn through digital mode, right? Across the globe. Even my schools are running digitally. I cannot even imagine. Kindergarten schools and children are on a digital mode of learning. So we can always do that. Yeah.
Perfect. And how important do you think it is to have an operating room specially designed for managing children and specific dental equipment in the facility? What advantages and disadvantages there are, in your opinion? Do you work in a hospital-based or in freestanding surgical unit?
Yeah, see, in the university, it's a part of the hospital. In my university where I teach residents, it's a part of the hospital. So we have 1 day assigned to pediatric dentistry. Every Monday we operate. Every Monday. Every week, Monday is our pediatric dentistry operating day. They have numerous number of theaters. We have a medical school, we have a dental school, and all the departments, there are around 700 faculties. So different people operate, and we have a Monday morning. But in the private practice side, where we always operate in the same setup, the dental center, just in front of the dental where we operate from a practice, there is a multi-specialty hospital. If anything, you can just immediately move the child to the hospital for intensive care. But all these things depends on the capability of your anesthesiologist. Okay, that's why I say you have a good anesthesiologist, you have taken care of most of the things, because they can, handle emergencies as well, So that's the key. And I'm operating for the last 20 years, and touch wood, we never have to move any child anywhere so far. And we have treated children with all medically compromising conditions. We have treated children with cardiac defects, ASD, ventricular septal defect, dextrocardia, you name anything, tetralogy of Fallot, everything. So till today, only 1 patient has been advised. My anesthesiologist said we will not give anesthesia for a Peary-Robin anomaly. Okay, otherwise the pillar, the foundation is the anesthesiologist. You get a pediatric anesthesiologist, your 80% of 90% of the job is done, then you just need the facility now. Whether it can be in the hospital, that's why I said you can go, instead of creating a dental center, if an existing hospital, which has an operating room, 10 pediatric dentists join together and go and talk to them and say, give us 1 day, okay, to start with. So out of the 10 pediatric dentists, 2 of them operate this week. Assume that only two patients are ready. So the next week, another 2, by chance, the other 2 pediatric dentists might have a case. So in a month, you have 4 or 5 procedures happening to start with. Then the hospital knows there is something, if we sustain this, more pediatric dentists will come and operate here. They will sustain that. So so that's why you need a team of people to work. Then one day, now we have to book the theater in my place 1 week ahead. So I need a day, I have to book 5 to 7 days, because the theater is booked 5 to 7 days ahead of time now, because all the pediatric dentists operate in the same place. So it will be cost effective, and the hospital also will run well, because it will become profitable as well for them as well.
Okay. And who performed general anesthesia for you and your team? It is a physician, anesthesiologist, or do you have a dentist who are specialized in anesthesiology to conduct this case?
In India, there is no anesthesiologist. I think there are 1 or 2 of them trained abroad who have come to India recently. That's what I heard. But I'm not, in my setup, even in the hospital, in the university, as well as my private practice, it is an anesthesiologist who gives anesthesia to children. It's not a dentist, or it's not a dental anesthesiologist. There is no training that is available in India for a dentist.
Okay. And you, just like ourselves, live in a very big country with unequal conditions of access to health service. Do you have a recipe for success in such conditions? Or how do we offer the best standards of care in ambulatory surgery in developing countries such as ours?
Yeah. See, what happens is, if you, for us, the procedure is very, very affordable comparing to in a hospital setup. If you have a dental setup, for a developing country, you have to keep it more affordable, more accessible. Even the cost, what I've told, the usual cost is around $800 for a procedure, including everything. That's the average cost here for a procedure, unless it's a 1 hour procedure, which might be around $600 or something, but most commonly it's around $800 is the cost for a procedure. This itself is a little expensive for many patients here in India. So some of them who cannot afford, we bring them to the university. The university offers the entire procedures. The entire procedure in one of the dental school here, they offer for $100. The whole procedure is done for $100. Okay, in my university, it's around $200 to $300 is the cost. So when you look at the developing country, if you have a setup where people work together, see, the hospital will become more affordable if more volume is happening, more number of procedures happen. They can work around, and if you have a good anesthesiologist who can handle the medicines and the gases efficiently, you will save a significant amount of cost in that. There are multiple areas where you can save cost without compromising the quality, without compromising the safety of the procedure or anything. So you need an anesthesiologist who can work with you. See, for example, the less number of hours they stay in the hospital is fine. It will reduce the cost for the child, right? So the anesthesiologist have to be in line with you. See, for example, I do a procedure for 2 hours. 1.5 hours down the line, I will tell the anesthesiologist, next 20 minutes, I'll finish the procedure. So he will taper the medicines. He will give the reversal. He will reduce the gas, slowly he will taper down. So we match recovery with my completion. So it's only 1 hour post-procedure, the child is under observation. So immediately we'll give water. Within 1.5 hours, the child is out of the hospital. So the less time in the hospital, less expensive, more affordable, more patients can afford. So you need a kind of multiple levels of coordination between anesthesiologist and dentist in terms of working on, without, even though it's a developing country, we can work around efficiently if you have a good team.
Perfect.
And
Professor
can I have some
Muthu?
questions for Professor Muthu as well?
Yes, of course.
Yes, sir.
Yeah, well, first of all, I would like to thank you for being with us today,
Thank you very much.
and to tell you that it was a brilliant lecture. And I myself am not a dentist; I'm a surgeon as well.
Okay.
So maybe I was looking much more for the practical setting, for the venue, the facilities you were using to handle your patients. And you brought everything that ambulatory surgery is, and everything that we need in our country, which shares lots of things with your country as well, like being
Yes,
a
yes, absolutely.
country, a very unequal country with
Yes.
many big cities as well, some cities richer than others. And we have this huge challenge, bringing the state of the art treatments for the most patients we can, and how to balance this with cost effectiveness and all of this. And I think you brought some of everything. And more specifically, you were working in a hospital, but also in a freestanding unit, and you were doing real ambulatory surgery in a way that the patient comes from his house, returns to his home after the procedure, won't stay longer than a few hours in procedure. You make it simple and somehow, and you work with the pathwork and with a team which is very committed to the patient. So I could see very clearly that the patient is in the center of the care. So, and this is right the title of this webinar series. So I'm very, very glad I could hear you talk with us today. So congratulations. And I would like to ask you.
Thank you very much. Yeah.
Oh, my pleasure. I would like to ask you how often you have to split in many sessions the treatment of the patients. I mean, how can you estimate a percentage, for example, of patients that you can handle in just one session? And how often you have to bring them back to the operating room?
Do you mean the same patient?
Yes.
You bring them back? Is it? No. Yeah. Okay. Thank you. So I got that. The thing is, we usually rehabilitate one child. We rehabilitate fully. It's one visit. The entire mouth is rehabilitated. Okay. So if you look at 10 years back, what used to happen is we rehabilitate these children at 2 or 3 years of age. Okay. And they come to the clinic and we ask them to come back for a follow-up. And many times they don't come back. And you come back after 1.5, 2 years later because they think everything is done. And when patients do like that, they come back with a different, again, new lesions because they never followed the preventive protocol to be done. But now we don't let that happen. So in the last 20 years, I have probably treated 3 or 4 children, second time under general anesthesia. Okay, second time, it's the same child. We treated 1 year back, you know, they come back a 1.5 years later, 2 years later, and again the child needs a GA because we treated at 2.5 years of age. 4 years, they go back and continue sleep time feeding practices. They don't perform the oral hygiene measures. They don't come back for the preventive frequent fluoride application visits, and they suddenly appear. Many times this has happened when they went abroad. They get the treatment done, they go abroad, and we didn't have a chance to interact frequently. Now the protocol, what we have in my practice is, you finish the procedure, the next day we have a review visit, we consult and tell them why the follow-ups or the next 2 years are very crucial. I want to see you 3 months from now, another 3 months, another 6 months. In the first year, I need 3 times, you have to come back to me. And the second year, I'll call you every 6 months, 2 visits. If all goes well, I tell the parents only 2 things you have to do. 1, never let the child go to sleep without brushing in the night. When the child goes to sleep, mouth should be clean. This is one thing The second thing, you come back to me for the follow-up. We will remind you from my practice. They will call you and tell you when the follow-up is. Just for the first 2 years, be with me for this protocol. And now, very, very rare. I don't remember in the last 7, 8 years, we never took the child for a repeat GA. But there are a lot of literature on this. You know, there's child coming back, but I realize, having spent almost 10 years in working on early childhood caries, this has really reduced the second GA for us for the same child. Okay, but if the follow-up is not implemented and practiced, and you operate at 2 years, 3.5 or 4 years, if they develop more disease, this invariably happens only if they don't follow your protocol, which is very, very unlikely in our centers now. But I read papers, there are a lot of papers on the need for a second GA, or, you know, they come back with new lesions in due course of time like that. So that's a brilliant question. Thank you for asking that. You know, that's a very important aspect in early childhood caries.
Yeah, and just to complement, I think this question, I feel that sometimes a full rehabilitation may be very time consuming. And so is there a limit of time of GA for a patient, for example, or does it depend on the age of the patient, for example, or the general health status? Up to how many hours would you, the maximum, would make a procedure?
Yeah. If you look at the, if I can put a rough percentage on procedures and general anesthesia, the more 80% of the children, 80% of the children will need 90 to 120 minutes, 1.5 to 2 hour procedure, maximum. 10% of the children might need 1 hour procedure. It's 45 minutes to 1 hour. There's another small 10% of children where all the 20 teeth are damaged, or all the molars, the primary molars, 8 molars needs pulp therapy and a crown on top of it. Then also anterior front teeth are damaged. You might need 2 to 2.5 or 2.5 to 3 hours. Maximum I've worked is 2 hours and 50 minutes or 3 hours in the last 20 years. So because you have the high-speed drill inside the operating room, and that can cut things pretty fast. So the longest I can say will be around 2.5 to 3 hours, but most common is 90 to 120 minutes, majority, 80%.
Thank you very much, Professor Muthu, and congratulations on that.
Thank you very much for asking very, very interesting questions as a surgeon. Thank you very much, sir. Happy to answer that.
Any other questions? So, Professor Muthu, I would like to thank you once again for sharing your vast experience with me and our audience today. It was very inspiring listening to you and all the ideas you brought today. I look forward to have you with us again in the next future. So thank you very much.
Absolutely. And it's a pleasure. And thank you for connecting with me. Thank you for the opportunity. I hope what you anticipated or what you were expecting, I could deliver, I hope. And it's a great privilege and honor to speak for the Brazilian Society of Ambulatory Surgery. And I wish you good luck. And please don't hesitate to get back to me if I can be of some help. Thank you very much for the opportunity.
Thank you, Professor. Bye.
Thank you.